Hi students, welcome back to INI-CET November 2024 recall, and I am doing the Pediatrics recall. I hope you have enjoyed this exam. Going back to the few of the questions, it looks to be a pediatric side, much simpler, but I am not sure what about the other subjects. So my job is today here to take you through a few questions which has been asked in these exams. If I look back, the April-May session, the pediatric part was a little on the tougher side compared to this session. Two disclaimers here today. First thing is there may be some overlap of questions from anesthesia as well as the ophthalmology, and my colleagues might have taken it. The second thing, these are purely recall based questions. Sometimes the question may be a little on the wrong side, or what we call it a stem of the MCQ may be wrong, and the distractors may be not the accurate ones. So please bear with us. So let us start this session. I hope all of you get into a good score, a good college of your choice, and definitely a subject of your choice. All the best. Let's start this pediatric recall. A 2-year-old infant brought to a pediatric emergency ward with complaint of profuse watery diarrhea for past 2 days. What is the cause of this? Profuse watery diarrhea, remember, it is always the viral etiology. But here we have only one or two virus has been listed out here, adenovirus. But if you look here, if I'm not sure, that's why I mentioned in the beginning itself, the distractors may not be the accurate ones. The rotavirus is the most common, followed by Norwalk virus, enterovirus, and adenovirus. So since I mentioned this is the most common cause, the viral etiology, and the most closer the diagnosis here, the adenovirus. So I will put the right answer as adenovirus as the most cause for a profuse watery viral diarrhea in this child. Similar questions, little on the tougher side. A 5-year-old child has been brought to emergency with complaint of hematuria. He has a bloody diarrhea 2 days ago. What will be the causative organisms? We know Shigella, Salmonella, and the E. coli. They are the most common cause for a dysentery, that is the mucus and blood in the stools. So here if you see again, I'm sure these are the not real distractors. In the competitive exams, no examiner will give such a easy distractors. So here it is the E. coli O157 versus H7 is the right answer. So there are 4 species of E. coli, or 4 strains of E. coli, which known to cause the dysentery. The first one is called as enterotoxigenic E. coli, and that is responsible for the traveler's diarrhea. The next we have here, as I mentioned, the hematuria as well as the bloody stools. So that is classically hemolytic uremic syndromes, which is caused by enterohemorrhagic E. coli. And then we have something called as a persistent diarrhea, which is caused by the enteroaggregate E. coli. And the last one, the strain which we have is known to cause little watery diarrhea, is by the strain enteropathogenic E. coli. So remember these strains enterotoxigenic travelers, hemolytic uremic syndrome by enterohemorrhagic, and classically these strains enteroaggregate known to cause persistent diarrhea and watery diarrhea by enteropathogenic strains of E. coli. Which of the following statements are true regarding hemolysis? ALP is elevated, gamma glutamyl transferase is elevated, serum heptoglobin is decreased, urobilinogen is elevated. The classical hemolysis, it is usually a pallor, a jaundice and a splenomegaly. This is what we call it as a hemolysis. It could be intrinsic causes or the extrinsic causes, or intravascular or extravascular causes. The hemolysis leads to the RBC breakdown. As a result, the serum heptoglobin being utilized by this breakdown of a hemoglobin, which leads to a decrease in the heptoglobin levels. And also, since there is a breakdown of the hemoglobin, so urobilinogen is increased. So the right answer is here, it is the serum heptoglobin is decreased because of the hemolysis and by uptake of the hemoglobin, and the urobilinogen being elevated. So the right answer is here, it is the C and D are correct in this statements. A couple brought their newly born baby to ophthalmology. I am sure this question has been repeated by my colleagues in this platform. It's a preterm baby. On examination, white pupillary reflex, we call it as leukocoria. Calcification also seen in the radiological imaging. What is the diagnosis? So all this retinoblastoma, Coats disease, congenital cataract, retinopathy of prematurity, all are associated with leukocoria or white reflex. But the question is calcification. Retinoblastoma is known to cause a calcification, Coats disease known to cause the calcification, but to a lesser extent. So here the right answer is the retinoblastoma. So the others are, the Coats may be a little distractor, but since it is a preterm baby, many of you think that it could be retinopathy of prematurity, but retinopathy of prematurity, it is the neovascularization. Again, the Coats disease is a neovascular disease, but here the calcifications are not seen, specifically in the preterm babies. So which of the following is true regarding neonatal resuscitation? 30 versus 2 ratio when 2 people are present. Adrenaline dosage 0.01 mg per kilo. Adenosine is given as intraosseous route. Chest compression should be at least 1/3 of the anterior-posterior diameter of the chest. The adrenaline dose is 0.01 mg per kilo. So remember, 1 in 1000 is the adrenaline available in India. But for newborn resuscitation, we require 1 in 10,000 dilution, which means you take a 1 ml of adrenaline and you can add 9 ml of a normal saline or sterile water, which gives you 1 in 10,000. So that is the strength, and which is equals to somewhere about 0.01 mg per kilo. Roughly we use this as a 0.3 to 0.5 ml of a 0.01 mg per kilo of a, or 0.03 to 0.0 ml per kilo we use as a IV infusion, and if you are using through the endotracheal route, it is almost 3 times 0.5 ml to 1 ml per kilo. The other definition, the distractors are not correct here. So, chest compression should be at least 2/3 of the anteroposterior diameter, and the ratio of a chest compression is 3:1. So, that is every 3 compression 1 breath we give it is. Roughly we give about 90 of a chest compression and 30 of a breaths in a 60 seconds. So, that is what we do. Okay. And there is no role for a adenosine during a newborn resuscitation. We have a very easy access through a umbilical cord as umbilical vein. So, there is no reason to go for a intraosseous route. So, what is the age of the child who can copy a cross, tell a story and go to the toilet? So, the cross generally it is of 4 years. The baby can be a dry by day around 3 years, a dry by night around 4 years, maybe little extended. So, roughly about 3 to 4 years. Telling a story of 4 to 5 years roughly. But if you look here, the right answer I strongly feel it is the 4 years. So, the 4 years a child can write a cross, tell a stories and go to the toilet. So, this is the right answer here. Jackson-Rees circuit is used for pediatric emergencies, cardiac emergencies, adult emergencies, trauma emergencies. I am sure this question maybe again might have taken my colleagues in the anesthesia platform. This is used for a pediatric emergencies. So, this is the classically the Jackson-Rees circuit, and you can see which is used for a pediatric general anesthesia. It is a low resistance and has got a very minimal dead space. So, that's the reason a fresh gas will be getting into the child. So, and this is used for a pediatric emergencies or pediatric anesthesia practices. So, the most common screening test done in newborn hearing, the answer is OAE, BARA, clap and smile, ring the bell. Again, I am sure these are not the right distractors, but this is what we got from the students who have appeared for the exams. So, right answer is autoacoustic emissions, and this is the universal screening we do for all babies. It does not take a long time, maybe a few minutes only. The sound waves are passed to the baby's ear and the reflection is taken up, and then based on that we will say that the child's hearing is intact or the hearing is being affected, which means that we give them as a refer and we usually repeat it after 4 weeks to 6 weeks time. So, the BARA is done in a high risk babies, specifically babies with a preterm and the babies with the meningitis, babies with the kernicterus or bilirubin encephalopathy, babies on the aminoglycosides for long period of time. So, and this is basically takes care of a inner ear, whereas the autoacoustic emissions is basically the middle ear and outwards. So, the most common is OAE, but most specific and in a high risk babies it is the BARA or ABR is the screening test we do in a newborn babies to assess the hearing. Methylene blue is used as antidote for mercury poisoning, phosphorus overdose, methemoglobinemia, aluminum hydroxide overdose. It is the correct answer is here methemoglobinemia. Reason, methylene blue is an antidote for the treatment of acquired methemoglobinemia, and which is also used for a methylene blue, specifically the IV methylene blue, which is not easily available, but it is also used as an alternative for a treatment for a ifosfamide neurotoxicity or refractory vasogenic shock, both in a pediatric and adult critical care cases. A 5-year-old child presented with gum bleeding, flow cytometry image was positive for TDT plus, CD11, CD20, CD22, and which malignancy is associated with this consistent pattern. The flow cytometry gives a accurate diagnosis of the malignancy, the blood malignancies, and here it is the CD19, CD20, CD22 positivity with TDT positive is being classically with a B cell ALL. So let us see that one, what kind of markers we get in a T cell, that is acute lymphoblastic leukemia. In a flow cytometry, we have a CD2, CD3, CD5, CD7, and they are classically T cell lineage markers. Whereas a B cell acute lymphoblastic leukemia, we have a common markers CD19, CD10, CD20, CD22, CD17, 9A, and terminal deoxynucleotidal transferase, which is present in the immature cells. So that's the reason this is the right answer. It is a B cell ALL. What happens the markers in AML? They are the CD13, CD33, CD117, CD34, HLA-DR, and often myeloperoxide positive. So what happens in the markers which is characteristic for chronic myeloid leukemia? They are the granulocyte markers. They are CD13, CD33, and also BCR-ABL fusion gene, which is detectable via FISH or PCR. So which test can detect aneuploidy? A FISH, karyotyping, PCR, Sanger sequencing. If you look here, both FISH and karyotyping can detect a aneuploidy, but more specifically, it is the FISH technique rather than karyotyping. Karyotyping may be a mass kind of or the gross detect the aneuploidy, whereas more specific, accurate is a FISH technique. So FISH is, there is a fluorescence in situ hybridization which uses the fluorescent probes to target a specific chromosomes or chromosomal regions. They are useful for identifying a specific aneuploidies like a trisomy 21. Karyotyping, a very traditional method, takes me about 10 to 14 days. FISH is faster, maybe approximately 3 to 4 days. Karyotyping, which allows the visualization of the entire chromosomes, making the ideal for detecting the large chromosomal abnormalities. Again, trisomy 21 and other trisomies. What about a PCR, which is a less specific, for which aneuploidies, and better for small scale genetic mutations, this PCR. Sanger sequencing, which is highly specific but not used for aneuploidy detection due to its focus on base pair changes. So the right answer is here the FISH technique, which is used for a more specifically faster, more accurate for a aneuploidies. And this is we have covered up. As I mentioned, most of these questions which has been asked in the INI-CET has we almost 90% of this we have covered up in our lecture notes. We have covered up our online classes earlier, and this is the one of the example I have shown here, and where we have covered up a different types of a test and to show how is the mosaicism and what is the specific test being involved in the detection of these aneuploidies. The next question is Anemia Mukt Bharat 6x6x6 includes all except institutions, beneficiaries, interventions, mechanisms. It is the 6 beneficiaries, 6 interventions and 6 mechanisms. Institutions is a wrong answer here. So this is the right in this one. So let us look into this 6 into 6 and 6. 6 target beneficiaries are classically children 6 to 59 months, children 5 to 9 years, adolescent 10 to 19 years. These are the different category. A pregnant woman, lactating mothers, the women of a reproductive age. So they are the 6 target groups. The 6 interventions are a classically iron and folic acid supplementation, a deworming, intensified year-round behavior change communication, we call it as BCC, testing and treatment for anemia, addressing the non-nutritional causes for anemia, and delayed cord clamping, which we do at birth, and it has got a good impact on reducing the iron deficiency anemia or any kind of anemia, specifically applicable for a preterm babies. 6 institutional mechanisms are, these are the implementations, monitoring, capacity building, supply chain management, convergence and partnership. So this again we have covered up in our lecture notes, the 6 beneficiaries, 6 interventions and the 6 mechanisms. So next question is, baby with breast milk jaundice, all are correct except need phototherapy? Yes. Most of the times the baby's bilirubin may go up to 15 milligrams per deciliter or maybe higher. Unconjugated? Yes. This baby's jaundice unconjugated. Present in the first week of life? Yes. And may extend a second week of life also. Required to stop breast milk for a short period? If you look, this is not the right answer here. So I would consider this. We generally do not even stop the breast milk. Even the books mention if you stop the breast milk for a short period of time, the baby's jaundice comes down drastically low. Reason, the breast milk contains the hormone pregnantiol. So pregnantiol, which interferes with the conjugation of the bilirubin. As a result, the baby can have a prolonged jaundice, a persistent jaundice, and the jaundice which is reaching near phototherapy range or exchange. But most of the babies do not go into a exchange level of bilirubin, or usually this does not cause the kernicterus. But be careful, we cannot neglect it, and here the correct answer is required to stop the breast milk for a short period may not be the right answer. Which of the following a live vaccine? Again, this is both this previous one as well as this one we have covered up in our neonatology classes. So here if you see, all are measles, rotavirus, influenza, they are live vaccine except the hepatitis B. So measles, influenza, mumps, polio, yellow fever and rubella. This is a simple mnemonic you can remember, MEMPIR. So measles, influenza, mumps, polio, yellow fever and rubella or rotavirus. These are all the live vaccines. The most common cause of croup: H. influenza, Streptococcus pneumonia, Staph aureus, parainfluenza virus. It is the virus which is responsible, and that's the parainfluenza virus. So classically these children will have a dysphagia, drooling of saliva, and they will have a difficulty in swallowing and the stridor. So maintenance of airway is one of the critical steps in managing these children with the croup. And this is again we have covered up in one of our classes by my colleague in the MedAce platform. Which of the following does not comes under the severe acute malnutrition? The pedal edema, we know that, all of you know that it is one of the criteria for severe acute malnutrition. Weight for height, again one of the criteria. So these all are the indicative of a severe acute malnutrition. Mid-arm circumference less than 115 millimeter, we say it is a severe acute malnutrition, whereas weight for age is not the correct right answer. So this is the does not comes under the criteria for SAM, and this is again we have covered up in our classes. The lecture notes here says that the ST score below -3 standard deviation. So the weight for height or weight for length is severely wasted in a severe, that is the severe acute malnutrition. As I mentioned, edema is there. Classically, you know that kwashiorkor is a nothing but presence of edema. Mid-arm circumference less than 11.5 centimeter or 115 millimeter, you know that it is the severe acute malnutrition. So the criteria of weight for age is not the correct answer for severe acute malnutrition. So dear friends, thank you very much for being with us and listening to these classes. Wish all the best. As I mentioned, expect you to be in a good college of your choice and subject of your choice. Have a wonderful day. Thank you.